Hello, my name is Ferdinand Mukumbang. I'm from Cape Town, University of the Western Cape, and I am here with my supervisor, Professor Brian van Wyk, who is the main supervisor of the study. And then I also have Dr. Sarah van Bell and Bruno Marshall. So the title of my study is a realist evaluation of the Adherence Treatment Club program in selected primary health care facilities in the metropolitan area in Cape Town. So I'm just going to give you a little bit background on the study. So South Africa is home to the largest number of people who are infected with the HIV virus, and an estimated 6.8 million people are living with the virus in the country. And we have an estimated 3.1 million people who have already been initiated on treatment. That is a good achievement that we have had, but the problem with that is that we have the healthcare facilities crowded with people in the main care stream. So because of that, the clinics becomes very noisy, and then the waiting times for treatment is very long, and then the quality of care decreases. And so we now will have the problem of the patients being retained in care and them being adherent to their medication. So MSF, Médecins Sans Frontières, came up with a model of care that they call the Adherence Club, which is a model to help these patients to adhere to their medication. And what they thought is that if we could group these patients in groups of 25 to 30 and not leave them in the main care stream, and then provide specialized care to them by giving them making sure that their medication is available, and then we have a lay counselor who is just going to do preliminary screenings. Are there any problems that you have? Are there any issues that you're facing? Rather than sitting all day at the clinic just to see a nurse or a doctor to tell you that everything is fine, here is your medication. So they could actually shift them apart and just have something done in an hour. So this is how the Adherence Club work within the care continuum. So when you're tested, you're now linked to care, and then you now are initiated on ART, and then if you show that you are stable clinically, by when we look at your CD4 count, it is more than 500, and we see your viral load, it is lower than detectable, and we also check through your clinic records and see that you have been attending your clinical appointments very well, then we consider you eligible for that program. So we thought that we are going to do a realist evaluation of this program, because preliminary study shows that it shows better retention in care and adherence. These patients show better retention in care and adherence to their medication. So we now decided now that we are going to do a realist evaluation of the implementation and the effects of this adherence program. So we want to look at the context in which the program works well, the mechanisms that make the program to work, and the outcomes after you put the context and the mechanisms together. So we don't want to know only does it work, we want to also know how does it work, for whom does it work, and why does it work. So we are going to go through three phases. So the first phase is that we are going to identify our program theory, and then after we identify the program theory, we are going to choose 5 sites, and then we are going to try and test this program theory in these 5 sites, and then come out with our abstract mid-range theory. Thank you very much.